Greetings and welcome to another lecture in psychopathology, specifically the psychopathology of children. Now, the next disorder that I'm going to be talking about are the mood disorders. Now, as with adults, mood disorders tend to be divided up into unipolar and bipolar. Now, these tend to be diagnosed in children around the age of 13. In other words, as soon as adolescence occurs. Adolescence is, of course, when children are transitioning into adults, and it's a time of a huge amount of upheaval, both physiological and psychological and sociological and any other logical you could probably think about. So it makes sense that you would tend to get depression and stuff around this age. There have been those that have diagnosed mood disorders in younger children. The problem there is figuring out what is a mood disorder and what is simply a child being a child. I sometimes, in a somewhat flippant, joking manner, suggest that all toddlers are bipolar because they seem to go very quickly from one extreme to the next. I mean, it's not true. It's a bad joke, but it has a kernel of truth to it, in that, you know, it's diagnoses younger than this tend to have to be pretty blatant. And in a lot of cases, I think kids are probably being diagnosed when they really do not have the disorder, or at least not enough for it to be a problem. It may be something that they could grow out of. But every case is different. What may also make it a little difficult to diagnose in younger children is that the symptoms don't always show up in the same way. In fact, with children sometimes and adolescents, instead of being the clinical depressed, they'll be irritable, they'll be grumpy, they'll be unhappy, they'll be easily ticked off. And again, this is kind of, when you're talking adolescence, again, flippantly, it kind of goes with territory. So it can be difficult to tell what's the difference between this and what's the difference between something that really, really needs to be fixed, needs to be taken care of. But if you're looking for the classic depressed mood in children and adolescents, you may not find it. Now, when bipolar disorder is diagnosed in children, and by the way, children here, they're basically meaning under the age of 18. It's why I sometimes say children and adolescents, to point out that it also includes the teen years. Bipolar is often comorbid with ADHD. Which makes sense, again, in a way, because we'll be talking a lot more about ADHD later, but that hyperactivity very often comes with problems with attention. In fact, in adults, it's less hyperactivity than more to the attention problem, the inability to concentrate, that sort of thing. And so bipolar disorder is often seen with it because with bipolar disorder, again, in both the manic and the depressive state, there may be problems with paying attention. So it does make sense that they may go together. In terms of causal factors, we know that bipolar here, as much as bipolar anywhere, runs in families. Bipolar does appear, as I mentioned in the earlier chapter, to be highly biological, and even unipolar depression can also run in families, and it does appear to do so here. But there is also a link with a more of a congenital thing, which is prenatal exposure to alcohol. Having a mother who drinks alcohol during pregnancy is linked with mood disorders in childhood. Again, it's a correlation, it's a link, we don't know this for sure, but it's one of those things that again suggests that it might not be a bad idea to stop drinking alcohol when a woman is pregnant. You can also see the more psychological things, again probably more for the unipolar than the bipolar. But we have negative life effects, we have learning maladaptive behavior from family, from friends, from the media perhaps, and this are also factors in these childhood disorders. The treatment is where things get really dicey, because there is quite a bit of evidence that treatment using, for instance, SSRIs, selective serotonin reuptake inhibitors, that are often used in adults in anxiety and depression can actually cause different side effects in children and adolescents. And in fact, the use of SSRIs has been linked with increased suicidal thoughts in children and adolescents. Now, it's not necessarily linked to increased suicidal behaviors. In fact, the use of SSRIs can indeed reduce suicidal behavior in both children and adolescents, but it does increase suicidal thoughts. So it's something that the caregivers, as well as the doctors of adolescents in particular who may be put on these, need to watch out for. We also don't know what long-term use of SSRIs that change the brain chemistry, that increase the amount of serotonin in the brain. We don't know what long-term use of that can cause to a developing brain. Brains do a lot of developing in both childhood and adolescence, and we don't know what any really psychoactive drugs might do to that developing brain. So, again, it's probably better to not go on these drugs if other things might work. And luckily, cognitive behavior therapy does seem to work. Changing behaviors by changing underlying thoughts does seem to help, particularly in the short term. Long term, it might require extended therapy. It might require, in those that have this long term, the use of, the careful use of medications. But CBT is definitely something to be considered when they're talking about treatment for this sort of thing. Now, the next couple of disorders are those that are found pretty much only in children and adolescents, starting with oppositional defiant disorder and conduct disorder. These tend to almost be one leading to the other. Okay? This almost tends to be that first you get this and then you get that, and unfortunately then you might get the next thing. We talked about the personality disorder, specifically antisocial personality disorder, and it does appear that both of these may be sort of run-ups to antisocial personality disorder. Oppositional defiant disorder is a recurrent pattern of negative, defiant, disobedient, and hostile behavior toward an authority figure that lasts at least 6 months. And the at least 6 month is the part that makes it a disorder. Because again, sort of like I was flippantly saying for bipolar, we know that children and adolescents have a tendency to have an hostility at times toward authority figures. Whether it's toddlers, with their me do sort of thing, or whether it's adolescents wanting more space, or it's not unusual to see. But the fact that it's lasting 6 months at a fairly high intense rate is what makes it a disorder. Now, for oppositional defiant disorder, it needs to begin by the age of 8. So it begins fairly early. And it has a lifetime prevalence of 10%. So we're talking 10% of the population is going to have this. Again, for the vast majority are not diagnosed, but it is something that needs to be dealt with. And it is dealt with. I mean, ask teachers, ask police, ask parents, and they'll tell you that this is something that is not particularly rare. There are 3 subtypes. There's the angry subtype that are just kind of pissed off at everybody, particularly the authority figures. There are the argumentative types that want to argue back. They don't just get angry, they decide to argue. And there's the vindictive parts that may not be angry or that may not argue, but are going to get you back. They're going to get you. When you think about it, you could probably think of examples of each of these subtypes in the media. Those that get grumpy, those that argue, those that are vindictive. And these are not uncommon in ways to try to get back at those authority figures. Conduct disorder is a little different. It's not just defying authority figures. It's basically violating rules and violating the rights of others. So, they will steal. They will, stealing is a big thing. They will beat up others. Because what does it matter? If you have something that I want, I'm just going to take it because I want it. And that's enough. It doesn't matter that it's yours. I want it, so I'm going to take it. It doesn't matter if there's a rule that I can't do this. I want to do it, so I'm going to do it. So it isn't so much that they're, getting angry or arguing or getting back at authority figures. They're simply ignoring them and simply ignoring the rights of others. This tends to show up around the age of 12. So it tends to show up later. And it also has a lifetime prevalence of about 10%, which is why some suggest that this basically is a progressive thing. And indeed, research suggests that. There's a lot of variability in how this is done. You may get the angry ones, the vindictive ones, the argumentative, defiant ones. You may just get the ones that are like, well, whatever, I'm just going to go do what I want. But it is almost always preceded by oppositional defiant disorder. If not an actual diagnosis, then a post hoc diagnosis. When conduct disorder gets bad enough, they look back at childhood behavior before the age of 8 and say, well, yeah, actually that was ODD, even if we didn't diagnose it. Causal factors, any of a number. There does seem to be a genetic predisposition, not for the disorders themselves, but perhaps to not being very verbal, which might also be why a lot of times we see this more in boys. Because you're going to get angry, you're going to be vindictive if you're not very verbal. You're just going to take things if you want them, if you're not very verbal. Instead of asking for them or asking how you can get them, you're just going to do it. There's also some mild neuropsychological problems. Some problems perhaps with memory, problems with processing, that sort of thing. Not enough to be a real, blaring, siren, but bad. And also difficult temperament. If you remember back from general psychology or developmental psychology, if you've taken it, there's various types of temperament, and difficult temperament is when kids don't want to have a routine. They get angry very easily. Infants. We're not talking even children. We're talking infants. So it sort of makes sense that a difficult temperament would lead to ODD, would lead to CD. And this does seem to be a genetic thing. You do tend to see this run in families, even when the child is adopted into a family without a history of it. Another thing is the earlier an individual develops conduct disorder, the more likely they are to progress into full-blown psychopathy or antisocial personality disorder. Whether it's because of lack of intervention, whether it's because it's more genetic, whether it's because it simply cannot be changed, we don't know. These are correlations, but there are things to keep in mind. There's also kind of a chicken and egg problem here, in that if you have a kid with oppositional defiant disorder or conduct disorder, very often they're likely to be rejected by their peers. They don't want to have anything to do with you. You're a troublemaker. You're a pain in the butt. Low verbal intelligence also. They can't communicate. A lot of kids, when they can't communicate verbally, will communicate by screaming or hitting or taking things, which may lead to the worse environment, which may lead to the symptoms getting themselves progressively worse. Again, it's kind of chicken and egg. It's hard to tell what came first, the personality traits or the environment that could just exacerbate the personality traits. Families in which this shows up very often have rejection of the child, very harsh discipline, very authoritarian neglect of the child. So again, it can be difficult to tell whether this is always genetic or whether it's environmental or, of course, psychology's favorite, a combination of the two. When we're talking treatment, we're talking a combination of things. As I mentioned before, when it comes to the anxiety disorders, it's really a good idea to not only focus on the child, but also focus on the parents or the caregivers, and focus on the family, and focus on the environment. To try to fix things that could make it worse, and there's a fairly decent chance that fixing things that exacerbate the problem will cause the problem then to get better, at least somewhat. It may not be something that can be fixed entirely, particularly if it's something that's pre-programmed, but it's amazing what the environment can do. Remember, with diathesis stress, if you don't have a stress to bring out the vulnerability, you're not going to have the disorder. And it's possible that even if we're talking a genetic vulnerability, that changing the environment might indeed help reduce that vulnerability, reduce the symptoms, reduce the disorder.